I'm Allison Brashear. I want to welcome you here today. I'm the Dean of the Jacobs School of Medicine. This is the Jacobs School of Medicine, also Vice President for Health Sciences. And we are thrilled to have just a wonderful program here for you today. And it is our second annual Health and AI Symposium. So we have over 200 attendees, either here in person or on Zoom. Hello out there. And we have a robust program. I also want to thank Dr. Jill Cizek, who has put this together. And she has laid out here really a vision for what we can do with AI in health. And I just want to start by saying that UB and the Jacobs School of Medicine, we are here to transform health in Western New York. That is what we want to do. And this is one of the most amazing tools that we're going to use to do that. We have many, many advancements. We have a great opportunity here because not only is AI used in routine blocking and tackling, someone mentioned doctor's notes. I have to sign all my doctor's notes at 5 o'clock today from Clinic on Tuesday. But it's in drug discovery, it's in data science, it's improving our operations of our health systems. It is really going to go into everything we do into taking care of health. And it's going to extend not just into the health sciences, but it's also going to go out into School of Management. We've got Dean Iyer here, School of Law. It's going to impact all of our lives one way or another. So I'm really thrilled. We have these strengths at UB. So in case you haven't heard, UB will be the home of Empire AI. And we also have our own Institute for Artificial Science and Data Science with Dr. Shong. He's going to tell us more about that. So we're clearly set up to have a real, not just vision, but operational effectiveness of UB and all of our partners here to really, as I said, transform health in Western New York. So I'm going to get started here because we have a really full-packed day. I want to introduce Dr. David Rhew. He is the Global Chief Medical Officer and VP of Healthcare for Microsoft. He's here to talk about probably everything, that he's really going to focus on the benefit of AI in healthcare. He's got extensive experience in digital health, a proven track record in improving healthcare informatics and initiatives at Samsung. He's going to talk about his vision for technology, but also improvement of patient care. We're thrilled to have him, and he's going to be here all morning. We have a great panel to follow his program, and welcome, Dr. Rhew.
Thank you so much. All right, looks like we have the sound working great. So a little background, David Rhew, I'm the Global Chief Medical Officer for Microsoft. I'm a physician, I'm a technologist, a health services researcher, and I've had about a 30+ year history of working in healthcare technology. But I think the thing that most people don't realize is that many moons ago, when I was an undergraduate, I was a computer science major, and this is in 1988, and my thesis was AI in healthcare. Okay, so 1988, there wasn't a whole lot going on, so we'll call it a lot of hallucinations in my paper. But I'll tell you what's happened. There's 3 things that have happened that have made AI something that everyone's interested in. So in 1988, very few people were interested in it. When I applied for medical school, people thought this was silly, but they let me in anyways. But what's happened is the technology has gotten a lot better. So that's the first thing. And it continues to get better. So oftentimes we look at AI and we make an assessment and we look at it right, maybe even today. But the reality is 6 months from now, a year from now, it'll be better and better. So it's hard to stay on top of that. The second thing is our expectations regarding technology and AI continue to rise. So what we used to think of was just more of an algorithm, like if then, and that was really great. We're now getting to the point where we expect it to perform above and beyond consistently, ethically, and there's many things that people expect. They expect information, real time, all of that is the expectation. And AI is starting to meet the challenge, but it's not quite there in some cases, but I'll talk a little bit about that. And the third is that the problems in healthcare have just gotten bigger and more widespread than ever before. Maybe we just didn't realize it, but access to care has become a major issue. The rising cost of healthcare, health inequities, there's across the board many things that we're struggling with. And interestingly enough, AI may be able to help. So I want to really touch on a lot of those areas to kind of give us a sense in terms of where the opportunities may lie. And so as we think about that, maybe the very first point would be to go back in history and talk a little bit about what is AI, because we have to ground ourselves on some of the definitions. And I'll tell you, you talk to one person, you talk to another person, you're going to get a slightly different perception. Oftentimes it's associated with ChatGPT, but what we oftentimes realize is that there are some folks that think of it purely in terms of just an algorithm, where it's nothing more than just if-then statements. And then you've got other folks on the other end that are thinking this is magic. And it's probably somewhere in between. The original concept of AI first came about in the 1950s when we were just trying to think of whether or not a computer could act like a human. And it did start out with algorithms, but it became very clear that the data could inform the algorithms, could inform the models, and you could have this process where it could learn from itself and learn from the other data sets. And that is this concept of machine learning. And so AI ML was chugging along for quite some time, but there was a dramatic increase in its capabilities in the past decade. And it's largely been in an area of natural language processing, where we now can take a look at things that are unstructured, that normally we'd have said only a human can interpret this, things such as text, voice, images, video, and all of that can be quantified, interpreted, codified, and analyzed, and basically made actionable. And so that is actually happening in parallel to all this other amazing stuff that we're seeing relative to ChatGPT and generative AI. So let's call that traditional AI just for the time being. Now, there's one other element, and when you think about where the data sets and how they're organized, we don't realize, unless you're a data scientist, that there are certain concepts that are actually very closely aligned to others. And when you think about that, you could almost imagine mapping it out into some kind of, we'll call a neural network, where you're now putting greater weight on the relationships between different concepts and different words. And mathematically, that allows us to be able to then determine potentially that next word or that next concept, that next pixel. Well, that was something that we had been thinking a lot about, but it really wasn't until the past few years when generative AI took off. And largely it's because the engines, the databases that we're looking at have so much knowledge in them, and they're so comprehensive that by following this, we could do things that we could never have done before, or could never have done it as efficiently. And so when I think of generative AI, I think of it in terms of doing three things very well. The first is it can find information from disparate sources very quickly, faster than a human can. The second is it can summarize that and put it into something that's understandable. And the third is that it can put it into the right format. And whether that right format is in the form of a clinical note, or if it's in the form of some kind of a form, or perhaps even in the form of code, these are the things that traditionally, all three of those tasks, we said only a knowledge worker can do all three of those. And now the computer can do it. And because the computer can do that, it's opened up brand new possibilities. And that's really what I want to talk to you about, in addition to the natural language processing. Now, one thing that we have oftentimes assumed is that it's one of these that will solve the problem. Actually, it's a combination. So I'm going to give you an example. Some of you may have heard of something called ambient clinical intelligence. So what ambient clinical intelligence is essentially the clinician has a conversation with the patient. The entire conversation is not only transcribed, but it's organized into a clinical progress note. And boom, as soon as you're done with that encounter, the note's right there. Now, you take a few edits to it, you upload it into the system, and it saves the clinician 50% of the time required to document to the EHR. Huge time saver. Clinicians love it. Patients love it because you're now talking to the doctor. There's a great upside to it. Well, how is it actually working? And everyone attributes this to generative AI because it's writing the note. Well, the very first thing that it's doing is identify who's speaking. So how is it doing it? It's hearing a voice, It's getting that signal, it's getting a signal from here, and it's recognizing that this signal is the patient, this signal is the provider, and sometimes this signal is the care provider. And being able to do that consistently is natural language processing, and that is something that is I'll call traditional AI ML. The second thing that's happening, now these words are being transcribed, but does it really understand what is being said? Well, this is where interpretation of those words is essential. And in many ways, you're back-end coding it to standard terminologies and nomenclatures. So when we want to talk about integration into different systems, it has to be mapped to SNOMED, ICD-10, and all these other areas. And that also is what we'll call traditional AI ML. Now, at the same time, we're now converting that into a medical note. This is where we're leveraging the generative AI piece. And then there's, I'll call automation, which integrates into the medical record. It's all those steps stitched together in a very seamless way that allows us to be able to call it ambient clinical intelligence. And that is the ability for us to start thinking about how we utilize this. It's not about one tool solving a problem. It's about breaking the problem into multiple different sub-steps, understanding which tool is the most appropriate tool, and then allowing us to be able to create a more streamlined flow. Now, simply doing that is something that's amazing, but what we've also found is that we sometimes have to go upstream or we have to go downstream because that in itself solves one problem, but it exposes another. So I'll give you an example. So like some of you that may be working in the electronic health record may have seen that in one of the large electronic health record systems, they have this mechanism where you can have a note, like your inbox, there'll be an auto-generated note. It'll have taken a look at it and it'll say, here's some suggested text for you to respond. And it's conceptually a great idea because now you don't have to start from scratch every single time. But what they found in some instances that it actually increases the amount of time that clinicians are spending writing notes and responding to emails was largely because now they're responding to everything as opposed to responding to just a select number. And so what they realized, and so this is some work that has been done out of Providence, was that they needed to go upstream. They needed to look at that and say, well, first of all, does it need to come to the clinician? Can it be sent to the pharmacist? Can it be sent to the receptionist for scheduling? And that triage is now being done upstream. And so what we sometimes realize is that it's not just that problem that we see that is in front of us, but it's all the other sub-steps. And we have an opportunity to start thinking about not can it solve the problem, but can we actually think about how we redesign the process? Because a lot of the tasks that are placed in front of us are not necessarily things that really need to be addressed by the individual at hand. And that's a great opportunity for us to start thinking about how we apply generative AI and traditional AI. So this has all been happening, but there's also one other thing that's happened. And this other thing that's happened is the reason why ChatGPT is the fastest growing internet application of all time. It's faster than any type of application you can think of. ChatGPT is faster than Google. It's faster than the Google search. Faster than chat or Snapchat. Facebook, Instagram, any of those. And the reason is because what was happening in parallel was they combined these and they put a natural language interface in front of this incredible reasoning engine, which allowed anyone, anywhere in the world to be able to ask a question and have this engine respond back. And you could ask it without any type of prior data science background. You just simply ask it like you would. Now, the thing is that we're realizing is sometimes people are so used to using search engines where they're looking for a specific answer that they're not taking full advantage of the fact that this is actually an agent for us to have a conversation with. In many ways, we have to learn how to ask the right questions to be able to get the right answers. And this is what we call prompt engineering, and there's a lot of strategies around it, but ultimately, this is how you maximize the performance with this. Okay, so with all of that as sort of a preamble, I want to maybe start talking a bit about, well, what is it that we can do with this new set of tools, and how is it going to transform AI, or how is AI going to transform healthcare, public health, and the society that we live in? And there's probably a lot of different things that I could have talked about, but I'm going to focus on these 4 areas because I think these are the ones that tend to be the ones that we don't necessarily always talk about. And the first is around this concept of screening patients before they even come to the hospital and the health system. This is something that we don't think of because we're used to having the problems at hand, but let's now think about the issues that occur before they get here, preventive care. The second is the fact that many organizations today are not performing in an optimal way. So that leads to decreased performance, increased inefficiencies, and also the opportunity for us to be able to compete in this environment, which is very competitive. We know specifically providers, the margins are razor thin. It's oftentimes very difficult to stay afloat. And so I want to talk a bit about how you do that. I want to talk about the opportunity to build a data system that is underlying, that allows us to be able to take advantage of the AI. If you think of AI as the engine to, let's say, a sports car, it has to run on fuel, and data is the fuel. And we have to understand how to be able to create the data sets necessary that are well curated, that are properly annotated, that can be used by the AI engines so that we can achieve goals. And this then opens up a brand new category, everything from research opportunities to safety and quality and a variety of other areas. And so I want to talk a bit about how data can be applied, and I'll use cancer as an example. And the last thing I want to do is I want to talk about the reasons why people may not adopt it. Could work great, could have a lot of benefit, but people will say, I don't trust it. It's going to lead to bias. It gets the errors raw. It's sometimes problematic. It's going to take away my job. Whatever the reason is, we have to understand that there are a lot of other factors that are necessary in order for this to be properly adopted. And I'll call that responsible, trustworthy AI. And how can organizations, how can society better implement this very powerful technology? Okay, so let's talk about the first one. The first one ties into this general concept of moving away from reactive care to proactive care. Okay, so what do we do today? Today, we educate patients. We tell them about diseases. We tell them about warning signs, and we expect them to be able to then go and see their doctor to do preventive things like vaccinations and screening tests. That is our strategy today for proactive care. Does it work? Sometimes. The majority of the time, it doesn't. And largely, if you ever go into an ER, that's when you know it's not working, because people come in with strokes, they come in with heart attacks, they come in with all these other issues. And we always say, I wish you would have come in earlier, or I wish you would have taken better care of yourself, all of those things. But that is moving upstream. How do you move upstream? Well, let's think about the way the system is designed. The design is a person has to come into the hospital, come into the clinic. They're motivated. They've got a symptom. They've got some reason to come in. Now let's think about the people that didn't come in. There are people that are at risk for disease. There are people that have a disease, but they don't know about it. And then there's people that have a disease and they don't realize it's actually progressed. That's the population that I'm talking about. Now, traditionally, a clinician, a health system would say, can't do a whole lot. We're sending out messages. We've got these public service announcements. It's up to them to listen to it and respond. Well, now we can. So I'm going to give you several examples of how we can. First is on imaging. When we do an image, and we take an image, whether it's a CT, chest X-ray, or any other type of image, there's a lot of information there, but usually we hone in on one element where we're trying to rule out infiltrate, or we're trying to do something, make sure that there's not a fracture. But there's a lot of information in those images that we as clinicians oftentimes ignore. Or sometimes it's picked up by a radiologist, but then as a busy clinician, the system ignores it. So let's talk a bit about that. And I'm going to start with the most basic image that every one of us has taken. It's getting your eyes checked. Because every one of us, in order to get your driver's license, in order to go to school, there's a lot of reasons why. If you have blurry vision, you go see your optometrist. And what's that machine? You put your chin on it, you get the goggles on it, and it says, is it better or worse? Well, there's an image taken during that time period, and typically that image is just thrown away. Well, not anymore. There are opportunities to be able to apply AI on top of it. So let me give you an example. So I'm an adjunct professor at Stanford University in Palo Alto, and Stanford has this medical center. It's called the Stanford Medical Center in Palo Alto. It's a tertiary care center, so a lot of times organizations, all our tertiary care services are there. There's a lot of satellite clinics throughout the entire region. They're in areas somewhat rural, like in Stockton and around other parts of Northern California. And people come in for routine blood pressure checks. They come in for routine primary care, urgent care, a variety of reasons. And so as part of their routine visits, for every vital sign, everyone gets their eyes checked. But what they're doing is they're running AI on those images that are taken at the time, and they're picking up things like diabetic retinopathy. Now, you would say, well, that's probably not that big a deal. I mean, these patients would have been picked up anyways. Well, the reality is many of these patients have not been. In fact, if you look at the HEDIS score for screening for diabetic retinopathy at Stanford and nationally, it is the lowest score. And it's not because clinicians aren't ordering it, it's because it's measured based on whether the patient actually saw the ophthalmologist. Now, imagine you're the patient in Stockton, which is many miles away from Palo Alto, and you've been told you've got diabetes, and they said, it's a good idea for you to get you checked, come in, see the ophthalmologist, and you're like, well, I've got to go take time off from work, I got to go there. Generally speaking, people put it as a lower priority. Now imagine the scenario where someone says, hey, we picked up something. If you don't go see the doctor, and you're going to go blind in the next couple of years. A lot of people are going. And that's that change of mindset, the change in approach completely changed the action. And so the HEDIS score for diabetic retinopathy screening actually went from very low to actually one of the highest in the nation. It's an example of how by making care easily accessible, affordable, you can screen large populations, we can actually do a tremendous value. Now, there's one other thing about this. That same image, we can also screen for cardiovascular disease, hypertension, hyperlipidemia, a whole series of ophthalmologic conditions, even neurovascular conditions that we're starting to see, things like Alzheimer's. Why is that possible? Because we're not just simply taking a look at just your eye, but we're actually looking at the micron level arterioles, nerves, and surrounding structures that allow us to be able to understand, is there something going on? It's almost like we're taking an MRI of your brain, but we're going really deep. In fact, there are some organizations that have been looking at this as a means to be able to assess things like complete blood count, hemoglobin, like the hemoglobin, hematocrit, the platelet count, because you can actually track the blood cells flowing through your arterioles over time, and you can track that. It's extraordinary. The eye, in many ways, is the portal to your entire body. Extremely inexpensive, and we have the technologies today. Now, today, diabetic retinopathy is screened for. It is FDA cleared. It's also CPT enabled. So that entire episode that was occurring at Stanford is actually all completely paid for, because every one of those patients that have been picked up is now getting paid for through CPT. Cardiovascular disease, chronic kidney disease, and a variety of others are right around the corner. And so we're now starting to see potentially a tremendous opportunity to apply this. Talk about another imaging study. And if you've ever been into a busy ER or an urgent care, you'll recognize that the number of patients in the waiting room is usually very large. And that means that if you're the radiologist getting all those films, you have very little time to cycle through them. And so typically what's done is we as clinicians will have to say, rule out something, rule out infiltrate. And the radiologist will say, no infiltrate, and they maybe look for a few other real obvious things, and then they'll move on. Well, what we oftentimes find is that when we look at those x-rays, there are incidental findings. Incidental findings may be things such as a vertebral fracture, severe osteoporosis, coronary calcifications, even lung nodules. And these sometimes are picked up on, and sometimes they're not. Well, how often are they not picked up on? Well, it turns out that 62% of the time, at least in this study, they had vertebral fractures that were not stated on the radiologic report. And if you look at the populations that come in, they tend to be older. So Medicare patients are one. 13% of all Medicare patients have a vertebral fracture in this study. Now, we're starting to realize that this is also another opportunity. So there was a group called Covera Health, and they decided we're going to actually attack this problem, and we're going to follow up on these. And for every one of these patients, we're going to do not only education, we're going to provide them calcium, bisphosphonates, treatment recommendations in terms of exercise and diet. And they found better outcomes, clinical financial outcomes, by doing this intervention, by looking at this. Now, here's the challenge. If we were to do this across the board for all the things that we're missing, we would overload the system. And so what we're now realizing, it's again, back to that concept of not just simply identifying the problem, but thinking proactively before and after, what can you do? We're starting to realize that we have to risk stratify patients. Highest risk patients need to be seen right away by the specialist. Medium risk patients can be followed up by the primary care. But the low risk patients, the ones that have like a nodule that you're following, has to be a separate process. It can't be sent to primary care. And you need to figure out a way to have these followed regularly, in which case then they continue to be assessed. A brand new opportunity for us to be able to address issues, but we need the infrastructure that supports it. Okay, let's talk about another challenge. So I started my career in the area of quality improvement. In fact, much of my work was around assessing quality of care across within an organization and between organizations. And the thing that I've concluded, and many others have concluded that have been in this space, is that there is a tremendous variation in care, and a lot of it is unwarranted. And we talk about evidence-based medicine, we talk about quality measures. There's certain things that everyone is asked to do. But then there's certain things, if you were to go to medical societies and they say that every patient should get these done, but we don't track it. So I'll use cancer as an example. In cancer, one of the things that we recognize is that patients should not only get all the standard quality things like vaccinations, but they should, for the tumor, they should have it should be assessed for biomarkers. And then the results that come back from that you should act on. You should put the treatment that is associated with that appropriate biomarker, and you should have that patient on that, so long as they're not having some adverse effects. It just seems logical. You're going to do that. The reality is, when you look at across cancer patients, a lot of times biomarker testing is not performed, and a lot of times patients are not put on the treatments, even though the report says that this is the best drug for this particular agent. They just happen to be placed on another agent. That happens all the time. And what we realize is that we need a more comprehensive way to assess this. So there was a company which has been doing this across multiple different areas. And what they found is that they can help identify, just by going through the medical record, gaps in care. And they can, in the process, identify miscoded diagnoses. In this case, it was many of them cancer. And then in addition, not just the miscoded diagnoses, but unidentified comorbidities that have a direct impact on patient care. So if you go back to cancer, these patients are placed on some pretty aggressive treatments. In order for a patient to respond, you have to have a certain constitution. You have to have a certain immune response that you can develop, or just an ability to handle the treatments. And if you are cachexic, you are weakened, you are unable to do that, it is very unlikely that you'll be able to do that. Well, it turns out that many patients have cachexia that are undiagnosed, and this process of scanning the medical records using the natural language processing can help identify, at least in a study of 7 National Health Services trusts, 522% more patients. This is a tremendous opportunity for us to start thinking about how we can identify patients that we don't typically treat, as well as those that for conditions that we don't typically look at. Let's start using another example. I talked about ambient clinical intelligence. So ambient clinical intelligence is designed specifically around the ability to help improve the workflow efficiency and improve the experience for clinicians as they have that interaction with patients. But now imagine that same voice recording, we use that for other purposes. So I'm going to give you an example of what's happening. Intermountain shared this. They are using voice as a biometric. So that exact same conversation with the patient and clinician's consent, they're using this as a voice biometric, and they're identifying, is the patient stressed, anxious, depressed? Is the clinician stressed, anxious, or depressed? They're actually doing both, and they're quantifying it, and they're measuring it over time with their permission. This is not, you're not asking the question, with the patient, are you depressed, are you anxious? They're just simply looking at the tenor, the quality of the voice. And we're starting to realize that we may be able to, just by using this voice as a biometric, help screen patients that we don't normally assess this for. And additionally, it is being used for a variety of other conditions. So at Hackensack Meridian, at Mass General Brigham, they are using this voice as a biometric to measure the overall progression of disease for Parkinson's, for other ALS, a variety of other neurovascular or neuromuscular types of conditions. And these are opportunities for us to be able to not only determine how it's going, but quantify it. Because sometimes it's very difficult for us to know, is a treatment working without a quantifiable metric? And so this is extremely valuable. Okay, So those are multiple examples of how we are starting to realize that we can go upstream. We can use this, but we do need to put the systems in place to be able to identify how to manage them. Second thing I want to talk about is none of this matters unless you can have resources and funding to be able to support that. And unfortunately, in many organizations, that is the rate limiting step. So the first thing I'd like to share with you is that AI can help in terms of improving not only operational efficiency, but it can also increase reimbursement. So there's a site some of you may know of called Emory. It's based in Atlanta. What they did is they said, we're going to hire a chief financial information officer who is going to take a look at AI and we're going to use this for looking at prior authorization, denials. We're going to look at the whole rev cycle. We're going to find ways to optimize it, and we're going to see whether or not that has an impact. First year, $70 million in increased revenue. Pretty good start for just one person in implementing it. Now, what was the lesson learned? It wasn't just that they're finding opportunities, but they also, when they hired the person, it was actually a surgeon, a retired surgeon or a semi-retired surgeon who is working in collaboration to communicate this with their peers, because it's not eliminating the work. What it's doing, it's identifying the opportunity, but somebody still has to fill out the form or do the work to actually get the reimbursement. And to ask your colleagues to be able to do that one extra step, let them know that this is actually going to get the reimbursement. That's the conversation that was highly effective. So it was actually a combination of both. You figured out what's going on, and then you had that conversation. And that has increase the opportunity. We're also seeing AI being applied in so many other areas. Oftentimes we don't think of them as being clinically related, but they are actually very clinically related. I'll start with the call center. The call center, it's many times people think of it just as a consumer satisfaction category. The reality is the call center is the very first opportunity for you to engage with the patient and get them to the treatments that are necessary. So let's imagine a scenario. Person makes a call, says, I'd like to schedule an appointment. And the call center says, well, let me connect you to the scheduler, or let me look at the scheduling. Here's the first available appointment. Done. Move on to the next call. Missed opportunity. Turns out that that patient lives 50 miles away, has missed their last 4 appointments, has no car, and traditionally has to use public transportation. But you have a program. It's called a rideshare program that is perfectly aligned for this patient. You have patients, you have multiple programs. You've got food service programs. You've got other things. Imagine when that person made that call, AI ran it through the background and said, this person's eligible for these treatments. Make sure that you enroll them into the program. Missed opportunity. That's how we can start thinking about how AI can be applied. Bring it to the front lines, not just frontline physicians, nurses, but the entire healthcare system. We've improved the overall operational efficiency. There's so many examples I can go, but those are just some classic examples. Okay. I was recently in Florida. I was with Advent Health, and Advent Health has a really neat system going on. What they do is they track everything that goes on within all the hospitals across their system, and they have this. You can see it looks like a FedEx kind of station where they're tracking every single patient, and they've got some amazing results. So they're listed on the right-hand side. So by simply looking at the data and having someone navigate that, they're finding tremendous efficiencies of care. And why is that? Because hospitals are not necessarily designed for efficiency, and certainly health systems are not. So if you are in part of a health system, a lot of times health systems occur because you're acquiring hospitals that have different infrastructure, and merging them into not only the common infrastructure, but the common processes is extremely difficult. And so oftentimes these systems run in parallel. I work with many sites across the world, and this has become very apparent that the inefficiency of these type of larger networks can lead to bad outcomes. So I'll give you an example. One of my friends went recently to London. His son had an injury, and he broke his hand.
Morning.
And he went to London.
How are you? I'm good.
Do I? That's kind of strange. Okay. We're on another line here as well. Okay. Okay. But yeah, that's right. So what happened was he broke his hand, and then they got an X-ray. And they told him that it'll be 2 weeks before this X-ray will be read. Okay, this is a child with a fracture on his hand or wrist or arm, somewhere around there, in 2 weeks, that will have already started to settle, and it will have to be rebroken in order for it to be assessed. This is unacceptable, but it's not uncommon. The number one issue in London, number one issue with the National Health Service, and one of the top issues across every health system is something called wait times. And I'm talking about just waiting in the ER. I'm talking about waiting for procedures, such as waiting for a total hip, a total knee, bypass surgery, things that, that oftentimes, we just assume, well, the system, I just need to wait. Well, why are we getting wait times? Well, one of the reasons is we have embraced this concept called center of excellence. So with centers of excellence, we say, if these are the sites that do these procedures all the time, they will have the best outcomes. Let's send everyone there. When you do that, the large tertiary care academic medical centers have wait times that extend over a year. But we also realize that not every procedure has to be done at one of these centers. It could actually be done in satellite clinics, other hospitals. And if we realize that we actually have capacity to be able to do that, we should load distribute. We should redistribute the actual work. And that's actually what's happening at NHS. They're starting to look across all the different procedures. What are the ones that actually need to be done by the top ones, and which ones can be redistributed? Now, there's a change management piece, because sometimes there's relationships that people have with certain doctors or certain hospitals and things like that. But the concept is that we are bottlenecking ourselves because of just common practice and things that we always do. And that is one of the things that we're starting to realize that we need to address. Okay, so imagine all that Advent Health Mission Control Center doing some great stuff. If they wanted to start tackling all these other things like risk stratification and being able to do that, they just need to add more and more people to do that. What if you could use AI to be able to start doing this and start scaling this? We could then use AI to identify who's at higher risk. We could then put them into the appropriate pathways. We could identify if a patient has actually gone from a higher risk to a lower risk, or a lower risk to higher risk. We could identify mechanisms to be able to track things that are very clinically related. If you've ever been to an ICU, I'm sure every one of us has, there's a lot of beeping. And I'll tell you, most people are ignoring it. In fact, some people will even turn off the machines. And we've seen that where it's actually been turned off and patients have had bad outcomes. This is a broken system. And if we have systems of alerting that people have turning off, there is actually no value in terms of the alerting, if that's the case. We have an ability with AI to sort all of that and figure out what's real, what's actionable, what's something that is important. But it doesn't always have to go to the physician as well. And what's that pathway? So having the ability to AI to do this, but that means that we have to start rethinking about our systems. You need to have the ability to have a mission control. You need to add AI, but you also need to have a mechanism where you can engage with patients. Back to the CRM system, the ability for us to be able to have that direct outreach. And that's the type of sort of internal collaboration that needs to occur in order for all of this to happen. Okay, so now let's talk about another concept. And I'm going to go back to March of 23, where I was invited to this meeting at the White House. It was for a program called the Biden Moonshot. And specifically, the goal was to talk about how can we improve care for cancer patients with colorectal cancer. And two speakers spoke at the very beginning of this meeting. The first was Simone Bozeman, and the second one was Craig Melville. So Simone Bozeman is the widow of Chadwick Boseman, who some of you may know was in the movie. He's been in multiple movies, but the ones that are most popular, I'd say, were the Black Panther ones, as well as he was in something called 42, and there's a few others as well. Craig Melville is a Today Show host, and he has a brother named Lawrence Meadows. Now, the very sad thing is that their loved ones passed away of advanced stage colorectal cancer in their early 40s. But here's the thing. If we would have applied the existing guidelines, they still would have been missed, because they had no symptoms, no family history, and these are younger patients. In fact, when they were diagnosed in their early 40s, they had metastatic disease. That means this was going on in the 30s. So how do we address this issue when we know this is happening, and yet we're not addressing it? Well, let's go back to cancer again. What causes cancer? Typically, there is a predisposition. It could be a genetic predisposition to cancer. And then there's environmental impacts that occur. And oftentimes those environmental impacts are things that are related to your environment. So for instance, if you live in an environment that has very poor food, poor opportunities for us to be able to do exercise, healthy living, these are all factors that oftentimes we associate with the zip code. And when you think about, like, why is zip code one of the greatest determinants of your outcome? Because it's all those factors combined. But over time, these repeated pressures with the predisposition to certain types of conditions will lead to worsened outcomes. And if we were to kind of bundle this all together, we realize that what we see within the health system is the smallest segment of all the overall things that impact the overall health outcome. Because we only see them regularly, once a year, twice a year. Let's talk about all the other times, 363 times a year that you're not seeing them. What's happening? The activity, the stress, the activities such as alcohol use, substance abuse, there's a lot of other things going on as well. Behavioral patterns, it ends up being the most important factor. Genetics, huge factor. Your environment, all these other factors. And so when you put all this together, you realize that our current system is not designed to be able to do truly comprehensive care. Now let's imagine a system where we had an ability to take all this information, to curate it, and to use AI ML to be able to do three things. The first is identify individuals based on those that kind of fall into higher risk categories, and we can visualize that. The second thing is let's cohort the patients so that we can understand patients just like you. If you've ever seen a patient and you said, I wish there was a randomized control trial on this type of patient, or there was some data that could tell me how to better manage it. And say, oh, well, let's go to ChatGPT or something like that. But you actually have the data in your system. It's just not easily accessible. So what I'd love to be able to do is I'd love to be able to say, for every patient that came in, let's imagine it's a patient of a certain age group, a certain ethnicity, a certain past medical history on a certain set of medications. I'd love to learn their longitudinal course because I'm about to start them on this treatment course, and I don't know whether or not I should tell them this is going to have a good outcome or a bad outcome. No clinical trial has ever been done, but maybe across the entire network it has been. Cohorting helps us do that. Now, the good news is like electronic health record companies like Epic and others are starting to create those capabilities for organizations to do that. But as we talked about before, EHR is just one component of the broader picture. So what you'd love to do is you'd love to be able to get all of that information available so we can do the proper cohorting. And then from there, we'd love to be able to predict who's likely to get into a bad scenario. So that's what the power and opportunity is. And we're starting to see, and this is just an example, if we think about multimodal data and AI, this is where the future is. The future is not just about one modality, it's about taking all this information and applying it across longitudinally so that we can understand the outcomes. And if we can capture data discretely, multimodal, longitudinally, it gives us an opportunity to be able to apply AI on it. And so this is an example of looking at a clinical trial for lung cancer. You've got imaging done at baseline, genomics done at baseline, histopathology, lab tests, clinical data. Then at later points, you're going to capture a different set of multimodal information. And then at a later point, you're going to capture a different set. And so this is the type of information that needs to be captured regularly if we intend to look at how this data can be useful. Okay, and the other thing is that there has to be an infrastructure that supports this. And so one of the things I want to share is, it's not just about throwing all this data into what we call a data lake. If you throw it all in there, it becomes what we call a data swamp. What you really want to do is you want to be able to understand how do you take the data sets and then normalize them into standards that we can utilize. So in healthcare informatics, standards would be things like HL7 or FHIR or OMOP. And then we want to be able to then take that information and then apply AI on top of it. That's the type of information infrastructure that needs to be in place for us to be able to truly take advantage of the AI. Okay, so once you have that in place, or even prior to that, we have an opportunity to start looking at opportunities to be able to solve some real problems. So I was given the opportunity to speak to the American Cancer Society's board of directors, and I shared with them sort of my point of view in terms of what I think they should do. And I said, first and foremost, continue what you're doing in terms of the research, because that's going to save people's lives.
But there's a missed opportunity, and the missed opportunity is to focus on things that are low-hanging fruit. And there's two areas that I suggested. One is gaps in care, which we talked about, and the second is clinical trials. So early in my career, I'm an infectious disease doc. I started my career in the 1990s with a lot of other folks in the area, dealing with AIDS patients or HIV patients. And I remember the time in which Magic Johnson was diagnosed with HIV. And back then it was a death sentence. I mean, HIV equaled AIDS equaled death. I mean, it was literally, we saw this all the time. And everyone was extremely sad. But the one thing that happened is Magic Johnson enrolled in a clinical trial with David Ho at UCLA. And this trial was involving something called highly active retroviral therapy, combination therapy. And it was the cutting edge treatment at the time. It saved his life. It saved billions of people's lives globally because we now have realized that that approach works. The current treatments with a lot of these conditions, like cancer in particular, are best done when you have precision medicine treatments, the most advanced immunotherapies, and they're all being done in clinical trials. Now, you look at clinical trials, look at these shocking numbers. 11% of sites failing to enroll a single patient, 37% of sites not meeting their enrollment goals. This is actually, in some sites, we're talking about these numbers are consistent when you go to like leading cancer centers across the country. Imagine community-based centers or like other centers across the globe. These numbers are potentially even worse. So what do we need to do? We need to actually figure out a way to get people into clinical trials. Well, how do you do that? So in the area of cancer, we actually have to look at multiple different areas because the first thing you have to do is you have to stage a person. You have to know where's the cancer, what's the tumor histopathology, what's the cancer stage. Well, that information comes from multiple different things you see on the right-hand side. It comes from the medical record, comes from the path results, the imaging results, the OR results. And if we could actually have a human do this, it would take extraordinary amount of time and effort. But we now have AI that can do it. And the AI can work extremely well in all three of those categories: the identification of the case, the diagnosis state, the tumor site, and the histopathology. So for those of you that are familiar with the area under the curve, ROC, a 0.98, 0.99, 0.99, it is near perfect. 1.0 is perfect. Anything over 0.8 is great. This is as good as you're going to get in terms of being able to do this type of AI. This AI is, and it's not something that, by the way, Microsoft is trying to sell. This is just something that is now available that people can use. And in fact, it's been shown to decrease the amount of time compared to a manual process by about 87% of time. It is extremely efficient, highly accurate, and it is a tool that we should all be using in order for us to be able to increase and adopt clinical trials. I don't know if this is going to work, but let's see if there's a video here. Okay, there it is.
Providing support to anyone affected by cancer. By leveraging Microsoft's clinical trials matching technology, Foreign Cancer built a clinical trial finder experience, helping patients to find potentially suitable clinical trials for their condition. Technology dynamically selects the most differentiating criteria, appears in the trial subset, generates qualification questions in a language patients can understand. Then uses patient responses to qualify them, filtering out any irrelevant trials and recommending potentially suitable clinical trials.
So this is taking it from one perspective. You've got a patient that wants to find a clinical trial. They ask a bunch of questions, and it filters all that information, does it real time. The other way, which is the more scalable way, is you actually have a whole bunch of clinical trials, and you want to find all your patients. You can actually do the same. It's actually very scalable. You can get a whole list of patients. You can do the direct outreach. Two ways to do it. Okay, so now let's talk about that last piece. None of this matters unless people use it. Why won't they use it? They don't trust it. We have to figure out ways to operationalize this. So there's a group called the Trustworthy Responsible AI Network, or TRAIN, that has been thinking a lot about how you could take responsible AI principles. And these are principles such as AI should be fair, it should be transparent, it should be explainable, it should, we should have bias that's mitigated, we should properly govern, all those factors, and say, well, what as an organization do you need to do to be able to operationalize this? And it's largely based off of the things that have already been agreed upon by organizations like the Coalition for Health AI, or CHAI. So we know what CHAI has said, that these are important things. They've identified what we call an AI lifecycle checklist. But as an organization, How do you know that what you're doing is actually going to be meeting those standards? And the second thing is, let's imagine that there's a site that did all of that. Can you definitively say that this AI is working for all your patients? Because the problem is that no one site has a large enough and diverse enough patient population to be able to truly answer all the questions. So you really now need to collaborate with other sites. But in order to collaborate, you have to standardize on your approach. Many years ago, there was a study that they looked at the impact of computerized provider order entry, or CPOE, on health outcomes. And they showed that this commercially available CPOE system saved lives. And then there was a study that came out several months later, the exact same system, they showed that it increased mortality. Okay, the exact same system, saving lives, the exact same system, increasing mortality. Why is it? Because the implementation was different. And when the implementation is different and the measurements are different, it's hard to compare apples and oranges. And that's why what I'm talking about is when you collaborate, you actually need to compare apples with oranges. There has to be some level of standardization in terms of what are you measuring, how are you measuring it, how are you implementing it, and how are you capturing it in a seamless way. If we do this in a way that every site does this, we can create what's called a federated AI outcomes registry. And that is where the industry is heading right now. We're starting to realize that we can actually do this, but we can collaborate with others. And the last thing is that in addition to operationalizing at the site level, capturing the information and being able to collaborate in a standardized manner with others, we can't leave other sites behind because there are several sites that are small, rural, that want to participate, but they won't have the capability. So we have to think about the strategy for that. So let's talk about train. To operationalize responsible AI, there are many things that need to be done, but let's just start with 4 basic questions. The first is, do you know all the AI that's running in your system today? Seems like a simple question, but you actually have to first define what is AI. Are we talking about clinical? Are we talking about operational? But once you define that, you need to have a mechanism to be able to capture that. And so what that begs is the need for what we'll call an online registration portal with something called model cards. Because what you want to do is you want to capture that information, you want to capture it in a structured way, and you want to be able to refer back to it. Second thing is, are you testing the AI on local data sets, both pre and post deployment? Now, this doesn't occur regularly. In fact, it doesn't occur oftentimes at all when you talk about post deployment, but it's really important that we test it on local data sets. We test it on local data sets, we can ensure that it's actually working in our site, and then we can start rolling it out. And then post deployment, the ability to assess it, not only is the algorithm working or the model working, but are the outcomes we're capturing going to be impacted. And if we look at subpopulations, this gets into the issue of bias assessment. What are the outcomes associated with certain subgroups? So if the model has any of these factors, age, race, gender, ethnicity, sexual orientation, religious affiliation, anything patient characteristics that are self-identifying, you're going to need to probably look to see whether those subpopulations are impacted either adversely, or positively, or negatively. That's the type of testing that we're talking about. That's the type of bias assessment we're talking about. And then there needs to be a governance process around this that's streamlined. It can't be throwing a lot of people at this. You have to find a way to streamline that. And there are now technologies that can help organizations down this path. And this is really what Train is doing. And in the process of we can standardize it, we can actually create registries. And the registries are going to be things that are not only valuable for AI, but they're valuable for safety, quality, so many other areas, research. And as you think about your overall structure for how you create a single data infrastructure that allows multiple different organizations to benefit, this is the opportunity for us to start thinking about that. Okay, one last thing. If we think about how data and information needs to be managed, one of the challenges they have is that sites do not want to share their data. And we have to recognize that. But in order to move forward, we can do federated learning where the models come to the data. But the problem is that not all model developers will want to share their models with every single site. So you actually have to have 2 things, federated and privacy-preserving environments. And what I mean by privacy-preserving environments, you have to have an environment where you can move the data, you can move the models, you can do the testing, but no one can actually ever see the data or the models. It's extremely important. It allows us to be able to do something called data collaboration without data sharing. It's an extremely important element as we think about how we can scale this forward. And we're now starting to see if we can do this, we could actually then collaborate with other sites, not only here in the US, but globally. And there are many sites right now. So this Train was launched in the US. I was just in a meeting where Europe is doing the exact same thing. We've got LATAM APAC, there's a whole bunch of other sites. But if we standardize, we can do this and we can collaborate in ways that were never done before. So let me just kind of summarize what we've talked about. AI is extraordinarily powerful, can do a lot of different things. It can help us think about problems that we've never thought about before. Largely, we focus on the things that are in front of us, but there's patients that we don't even see that we can apply this to. We can improve our own operational performance to make sure that it works better. We can build the infrastructure that's necessary, will allow data to be very useful, but we have to do it in a way that fosters trust. And if we can do this in a way that fosters trust, it'll ultimately create great opportunities, not only to leverage the use of AI, but also ultimately improve health equity and improve outcomes. Thank you very much.